Okay, so we're back, and now we're going to talk about guidelines for dressing selection. Now, let me just tell you, we're going to go over this in a lot more detail when you come on site for Bridge Week. So you'll have the opportunity to actually handle the dressings, see how they interact with fluid, etc., etc. But what I want to do right now is just walk through the basic guidelines for dressing selection, kind of walk through with you some of the things on your handout in your module. And hopefully that'll make it a little bit easier for you in studying for your exam. So I decided I'm not going to use PowerPoint for this. I want to be able to show you different dressings. So I'm just going to walk you through what's on your handout in your module, and then we'll look at the dressings. So we're going to start looking at factors to consider in selecting a dressing. Now, like we said in the previous presentation, most of the dressings on the market provide what we call passive support for wound healing. And what we mean by that is they absorb exudate, they maintain a moist wound surface, they provide for atraumatic removal, they provide a bacterial barrier, some of them do. Some of them help to insulate the wound surface. But none of them are actively manipulating the repair process. They're just supporting the cells that are doing the wound healing. They're supporting the fibroblasts by creating a favorable working environment. Now, when you go to select a dressing, and you're going to see this in the decision grid that we provide you and also in the way that we present the dressings, but you have to think first of the dressing that goes into the wound that's going to be in direct contact with the wound surface. And you're going to select the dressing that's in direct contact with the wound surface based on the depth of the wound and whether or not there are any tunneled or undermined areas. For example, if I have a wound that's very shallow, I can just take a flat dressing and put it on that wound, and it will be in direct contact with the wound surface. But if I have a wound with depth or tunnels, then I need something that I can either tuck down into the wound and tuck into the undermined areas, or I might need something that can actually go into a tunnel. If it's a very narrow tunnel, I might need a very narrow packing strip, which I really do have here if I can get it out. So if I have a wound that has depth or tunnels, I'm going to select my primary contact layer is going to be something that can tuck in, under, around, or that I can tuck into a tunnel. If I have a wound with depth or tunnels or undermined areas, so I'm going to start with my contact layer that fills, but then I'm going to use a cover dressing as well. So wounds with depth or tunnels need both filler dressings and cover dressings. But wounds that are very shallow, no tunnels, no undermined areas, need only a cover dressing. We'll keep coming back to this. Now, the second thing is you can look at dressings in terms of their ability to manage exudate. So a lot of the dressings on the market are designed to be absorptive, to handle wound exudate and to pull it away from the wound surface. And these dressings would be appropriate for wounds that are wet, that have moderate to large amounts of drainage. In contrast, if you have a wound that's relatively dry, you're going to want a contact dressing that provides moisture, that is hydrated. As you see at the bottom of the page, if you're looking at your hard copy module, when you look at the dressings that are on the market, your gels, your transparent adhesive dressings like Oxide and Tegaderm, those are hydrated. In contrast, your alginate dressings, your hydrofiber dressings, your foam dressings are all absorptive. And we're going to talk about each of those in more detail. Now, a couple of other things to think about before we get into the specifics of dressing selection, guidelines for dressing selection, are the impact of occlusion and the impact of adhesion. Out of all the dressings on the market, hydrocolloids are the only dressings that are totally occlusive. And when we say that hydrocolloids like Duoderm, Replicare, Comfeel, when we say they're totally occlusive, we mean that they don't allow any communication between the wound and the outside world. Oxygen cannot penetrate this dressing, so there's no oxygen transfer from the outside in. Moisture vapor cannot evaporate. So nothing goes from the wound surface into the environment and nothing goes from the environment into the wound. Now, of course, the advantage is it gives you great protection against bacterial invasion. But the difficulty is, first of all of the fluid is trapped at the wound surface. And the only absorptive factor you have is the dressing itself. So once the dressing's absorptive capacity is overwhelmed, fluid just sits on the wound surface. Typically, hydrocolloids are indicated only for wounds with very little drainage. The second concern is, what if I have a wound that has anaerobic infection? Then I can't get any oxygen from the environment into the wound base, and I'm creating an environment that's very, very anaerobe friendly. So current guidelines are, do not use hydrocolloid dressings on infected wounds. One, because it's totally occlusive and seals the wound bed from all oxygen. But also because most of your infected wounds will be highly exudated, and these dressings can't handle much exudate. And thirdly, because infected wounds require frequent assessment, and these dressings are intended to be left in place for 2 to 3 days. What about adhesion? If you have a patient who has a skin tear and has very fragile skin, in general, you want to select a dressing that's non-adhesive, that you can secure with wrap gauze, or you want to select a dressing that has skin-friendly adhesive like silicone. In contrast, if you have a wound on the trunk, it has to be adhesive, and the adhesive has to be secure. So trunk wounds, you always select adhesive dressings. Extremity wounds, frequently you will select non-adhesive dressings. Okay, now come to the grid for dressing selection. If you're looking in your hard copy module, it's going to look something like this. If your module was printed, let me check this out, in September 2012, then you'll be on page 137. And what you'll see we've done here is we've created a very simple grid that guides decision making. And this is the way we want you to think about dressing selection. This is the way we want you to teach your staff about dressing selection. Now, if you look at the top, it's going to give you general guidelines. And it's first going to tell you or your nursing staff what are the critical assessment parameters. Okay, well, they are 3 things. First of all, does the wound have depth or tunneling or undermining? If there's tunneling or undermining, we already know that we need a dressing that will tuck into a tunnel, tuck into an undermined area. In terms of depth, if there's significant depth, we know that we need a dressing that either will conform to the wound bed, that can be tucked into the wound bed and tucked under any undermined areas. Now, on your handout, you'll see that we've used 0.5 centimeters depth as kind of the cutoff between a wound with depth and a shallow wound. But don't feel locked into that. You have to use your judgment. Basically, when you're looking at the wound, you want to ask yourself, do I need a dressing that tucks under little areas and that intimately conforms to the wound bed? Or can I take a solid dressing and just put it on top of the wound and know that I'm going to have good contact between my dressing and my wound surface? That's the basic bottom line. You want good contact between the dressing and the wound surface. So first of all, determine depth, tunneling, undermining. Secondly, determine volume of exudate. Is this a wound with very little or no exudate? This is a wound with moderate to high volumes of exudate. We consider moderate to high volumes of exudate to represent wet wounds and minimal to no volumes of exudate to represent dry wounds. The third thing you need to consider is, where is this wound located? And specifically, is it located in an area exposed to urine, stool, or other contaminants? Because if the answer is yes, your cover dressing, your outer layer, needs to be waterproof to provide a bacterial barrier. Once you've gathered this data, you can classify the wound as deep and wet, deep and dry, shallow and wet, or shallow and dry. If there's practically no depth, let me back up. If there's depth or tunneling or undermining and a lot of drainage, it's deep and wet. If there's depth or tunneling or undermining but practically no drainage, it's deep and dry. If there's no depth, no tunneling, no undermining, but a lot of drainage, it's shallow and wet. And if there's no depth, no tunneling, no undermining, and very little drainage, it's shallow and dry. When you're studying, this is how we want you to study. Because we're not going to ask you details about dressings. We want you to be able to recognize the assessment parameters that tell you whether or not you need a filler dressing, depth, tunnels, undermining. We want you to recognize assessment parameters that tell you you need an absorptive versus a hydrating dressing. So let me give you an example. We might tell you on the exam, you're asked to see a patient with a right trochanteric pressure ulcer. On assessment, you find a wound that measures 6 centimeters by 5.8 centimeters by 2.5 centimeters with undermining from 2 o'clock to 6 o'clock. The staff reports high volumes of exudate. You should already know that that wound would be classified as deep and wet. You should know that you're going to need a filler dressing that absorbs and a cover dressing that absorbs. And that's what we're going to go through right now. We're going to go through the different dressings. I'm going to walk you through what's in your module. But when you're studying, you want to primarily study this grid. Okay, so let's talk first about deep, wet wounds and what your options are for filler dressings and what your options are for cover dressings. Our goals are pretty clear. We have a wound with depth or tunnels or undermined areas. We have a lot of drainage. We want to wet fluid from the tunneled or undermined areas into the base of the wound. We want to have a highly absorptive dressing in the base of the wound to handle the exudate. We want a cover dressing that provides backup absorption. And if the wound is in an area where it will be exposed to urine or stool, we want that outer layer to be waterproof. So you see on page 138, if you're in the September 2012 version, that the first option for your filler dressing is a calcium alginate. Now, a lot of you have used calcium alginates, and so you know that they come in plain and silver. They come in flat and rope. They're seaweed-based dressings. They're very lightweight, but they absorb about 20 times their weight in exudate. So they handle moderate amounts of exudate. They absorb into the dressing. The dressing becomes very soft. That makes it very easy to remove the dressing without trauma. Most of the time you change alginate dressings every day or every other day. If your wound is very deep and very wet, so I'm trying to create a deep wet wound, you see how I've just lined the wound with the alginate? And then I could use dry fluffed gauze to fill the wound and then a cover dressing. We don't usually layer alginates on top of themselves just because it's a waste of money. I want the alginate in contact with the wound bed because I want it to absorb into the dressing. I want to create a soft dressing that's easy to remove without trauma. But beyond that, I can just use dry fluffed gauze for backup absorption because that gauze will not be in contact with the wound bed. One other thing I should tell you about alginate dressings is that they come in two types. One type was what they call high gelling, and the other type is high integrity. If you have an alginate that's high gelling, it means that it's going to interact with exudate over time to form a thick gel. That can be very disconcerting for staff because when they go to change the dressing, they feel like they're not getting it all because there's just pieces of it remaining. The other type is high integrity. High integrity alginates absorb into the alginate. They do not come apart. They do not break down into a gel. And most of the time, they're easier to sell to your staff because they know that they put it in one piece, they got it out in one piece, and it feels much better to them. So ask your vendors, is this a high gelling or a high integrity alginate? If you prefer to have high integrity and what you have is high gelling, ask them if they have a high integrity alginate. Many companies have both. Okay, the next one is your hydrocellular or hydrofiber dressings. The one that most people know about is Aquacel and Aquacel AG. So based on Aquacel and Aquacel AG, you know it comes in plain and silver, it comes flat and rope. It looks a lot like an alginate, even feels somewhat like an alginate. The main difference is that as fluid is absorbed into Aquacel, into your hydrofiber, it turns into a solid gel. Some clinicians prefer alginate, some prefer the hydrofiber. They can be used somewhat interchangeably with the same guidelines, meaning typically we change them daily or every other day. If I have a very deep wound, I can line with the Aquacel and then lightly fill with gauze. If I have a tunneled area, I can tuck my Aquacel rope. This is one area where there is a difference between the hydrofiber rope and the alginate rope. Those of you who have used both of these know that alginate ropes tend to separate and fluff and leave little pieces behind. We do not like to use alginate ropes in very narrow tunnels because we cannot be sure we got it all out. It's fine for undermined areas and wide tunnels, but not for a narrow tunnel. In contrast, with a hydrofiber rope, hydrocellular rope, there's top stitching to prevent any breakdown, and you can actually cut this if you need a narrower strip. So I would not use alginate rope in a narrow tunnel. I would feel comfortable using hydrofiber rope in a narrow tunnel, and I would trim it if needed. Okay, the third thing that's listed, and this is on page 139, is your polymer absorptive dressing known as gold dust. Now, first of all, I have to tell you there's no gold here, and it's not a step up from silver. I don't know why they named it gold dust, but basically this is the type of polymers that are used in diapers. Super absorbent. So they lock exudate and form a very soft gelatinous mass. When you come on site for Bridge Week, we'll demonstrate that you can mix this with about 30 cc's of water or saline to form a thick applesauce. And then you can put a thick layer across the base of the wound and lightly fluff dry gauze on top. And this will continue to absorb and continue to absorb and continue to absorb. And you will be amazed at how much it absorbs. Now, why is it that most of you have never seen this? Because the company that makes it, Southwest Technologies, they have a wide variety of products, and wound care is just one of their product lines. So you might not have seen any of their products, but also this has use for crater wounds that are not tunneled. But you could not use this on a surface wound, and you could not use it on a tunneled wound because you've got to be sure you get all of the soft, gelatinous mass out. So it's kind of a niche product, but it's in your information because you need to know about it. Because if you ever have a patient with a deep wound that's highly exudative and you're trying to reduce dressing change frequency, this can help you do exactly that. So we will show you this on site. Now let's talk about gauze. Gauze, the old standby. This is one thing I know you all have. But notice that we want you to distinguish between woven and non-woven gauze. Woven gauze is like Kerlix and 4x4s, and we've all used this, and it's called woven because it literally is an open weave, so you get these great big pore sizes, and because it's an open weave, you also get these little strands that come out and can be left behind and can become foreign bodies. Because it's very porous, the exudate tends to pass through for absorption by the secondary dressing, and the bottom layer tends to stick to the wound surface. I'm trying to get this open enough to show you if I can. Okay, so this frequently is adherent to the wound surface and causes trauma with removal or leaves the little fibers embedded. So generally speaking, you do not want to use woven gauze in contact with the wound bed. It's fine as a wrap to secure another dressing. It's also fine if you've lined the wound with an alginate to use dry fluff woven gauze on top of it, because then it's not in contact with the wound bed. But if I have a necrotic wound and I want to use Dakin soaked gauze, I don't really want to use woven gauze because it would be in direct contact with the wound bed and could leave fibers behind and could cause trauma with removal. In contrast, non-woven gauze, like Cling or Me-Salt or New Gauze, can be safely used in direct contact with the wound bed because, as you see, there's no linting, there are no loose fibers, nothing can stick to the wound bed and act as a foreign body. So if you are going to use gauze in direct contact with the wound bed, you prefer to use non-woven gauze that will not create a foreign body effect, is much less likely to stick to the wound bed and to cause trauma. You want to think woven gauze as an outer wrap or as a secondary filler. You want to think non-woven gauze if you're going to put it in direct contact with the wound bed. And again, we'll look at this more when you are on site. And you're going to see more and more of the non-woven gauzes. Now, one specialty gauze is known as Me-Salt. And this is a non-woven gauze that's impregnated with sodium chloride and then dried. So it has a hypertonic effect, a positive osmotic effect, and if you tuck this into a tunnel, it actively wicks fluid from the tunnel into the base of the wound because the salt attracts the fluid. There's another one that you see listed on your handout. Some of you might have used Tender Wet, which is a gauze impregnated with lactated ringers and is very effective in cleaning up dirty wounds. And finally, I'm pretty sure that all of you have access to New Gauze. New Gauze is non-woven, as you see, okay? No linting and no loose fibers. Comes in a variety of widths, and it's perfect for tucking and wicking narrow tunnels. When you're on site, I'll show you the difference between New Gauze and iodoform gauze, and we'll talk about why you want New Gauze, not iodoform gauze. We'll also talk about the fact that Kendall has an AMD packing strip that's basically New Gauze impregnated with polyhexamethylene biguanide. So if you have physicians who like to use iodosorb, iodoform, I'm sorry. If you have surgeons who like to use iodoform gauze, which is this impregnated with a combination of iodine and formaldehyde derivatives, very effective against bacteria but very cytotoxic. You can hopefully cross them over to a PHMB gauze packing strip so that they get the antibacterial effects but they don't get the cytotoxicity. Now, as you see at the bottom of page 139, there are other options for narrow tunnels because you're going to have a lot of wounds with narrow tunnels. One other option, this is a little silver packing strip. So it's in silver impregnated fabric. This is Silverline by Argentum. But the bottom line is, when you look at what you have on your formulary, you want to make sure that you have at least one good option for deep wet wounds. That would mean either alginate, flat, and rope, with and without silver, or hydrofiber, flat, and rope, with and without silver. You probably will not stock Gold Dust, but you might order it on occasion. And you want to make sure that you have something that's appropriate for narrow tunnels. So plain U-gauze, packing strip with PHMB, silver wicking strip, any of those are very appropriate. Now come over to page 140. Let's say I chose an alginate liner. So I've lined my wound with alginate. I've done dry fluff gauze on top. Now I need a cover dressing. And my cover dressing needs to provide backup absorption. If it's a trunk wound, it needs to provide secure adhesion. And if it's in an area where there's exposure to stool or urine, it needs to provide a waterproof bacterial barrier. And of course, we all know cover dressing, so we could use a plain gauze tape combination, either a commercial version or gauze and tape. And that's fine if we do not need a waterproof bacterial barrier. But if our wound is in the trunk and if there's exposure to stool or urine, the outer layer has to be waterproof. One option would be to put down my gauze and tape and then cover with Oxide or Tegaderm, and that would waterproof it. Another option would be to use a waterproof adhesive foam that would give backup absorption, would give adhesion, and would be waterproof so that there would be no penetration of stool or urine. So that's deep and wet. You're going to select a liner that will not stick to the wound bed but is absorptive. You'll do dry gauze as a secondary filler if necessary. You'll make sure that any tunnels or undermined areas are wet, and you'll select a cover dressing that gives backup absorption and a waterproof barrier if necessary. Now we're going to move on. We're going to move all this stuff over, and we're going to move on to deep, dry wounds. Now, to me, the poster child for a deep, dry wound is a dehisced abdominal incision, and we have lots of those. And in that case, we have a wound with obvious depth. There may be some tunneled or undermined areas, but typically there's limited exudate. Most commonly, these wounds are handled with damp-to-damp gauze, changed 2 to 3 times a day. But as you know, many times when you go back to change the dressing, it's sticking to the wound bed, and you moisten and moisten and moisten, and it's still uncomfortable to the patient. What does that tell you? The gauze is drying out and sticking to the wound bed. You can make 2 very minor changes in your standard damp-to-damp gauze dressing protocol that will significantly improve outcomes. So the first, on page 140, you see about amorphous gels. And amorphous gels are nothing more than liquid gels. So I'm hoping you can see that I'm just spreading this gel. And I would take my gloved finger and I'd spread it all over the wound surface. And what's that going to do? It's going to keep the gauze from sticking. It's going to keep the gauze from drying out. So it's going to keep the wound bed moist and protected. So I'm going to put a thick layer of gel all across the wound bed. Then I'm going to get my non-woven gauze, moisten this with saline, and fan fold this throughout the wound bed. So lightly fill the wound with the damp, moistened gauze. Well, damp and moistened is the same, I'm sorry. With damp, non-woven gauze. So I've got gel, I've got damp gauze, and then for my cover dressing, I'm going to use a transparent adhesive dressing. Because if I put a transparent adhesive dressing over the wound, think what happens. First of all, you get very good adhesion all the way around. So your dressing is much less likely to fall down to the base of the wound. Secondly, the transparent adhesive dressing has no absorptive properties, so it keeps the gauze moist. Thirdly, it gives you a superior bacterial barrier, which allows the patient to shower or whatever. And because it's transparent, you can see exactly what's going on. If you change your standard protocol to gel plus damp gauze plus transparent adhesive dressing, you can typically change dressing change frequency, reduce dressing change frequency to daily or every other day. What other options would you have? You can also get gel-soaked gauze, so it's kind of eliminating a step, but many times that's not readily available, and most of the gel-soaked gauzes are actually woven gauze instead of non-woven gauze. So some of us prefer to put down a layer of gel, then our damp non-woven gauze, and then our Oxide, Tegaderm, Bio-Occlusive, whatever you have. Okay. Now let's talk about, oh, and of course, does liquid gel come with silver? Just in case you were that. Of course it does. Everything comes with silver. Now let's talk about wounds that are shallow and wet. So by definition, this wound has minimal depth, no tunnels, no undermining, but a lot of drainage. Many of your pressure ulcers will end up falling into this category once they're granulating and close to the surface. Venous ulcers are typically in this category. Sometimes your neuropathic ulcers are in this category. Large skin tears are in this category. So let's talk about what would be appropriate. We don't need any of our wicking products, so we don't need ropes, anything like that, because we have no tunnels, no undermined areas. One of the most commonly used dressings is your foam dressings, because foam dressings are highly absorbent. They're much more absorbent than your hydrocolloids and much more absorbent than gauze. Now, foam dressings, as you see at the base of 141 and 142, come in several different versions. First of all, they come plain and they come with sulfur. They come in variable thicknesses so they can handle different volumes of exudate. Also, they come non-adhesive. This has no adhesive, this has no adhesive. You can also get foam dressings that have an adhesive border. So the foam itself is non-adhesive, but the border sticks. Or you can get a fully adhesive dressing where it's adhesive all the way across. Here's our recommendation. If you are dealing with an extremity wound like a large wet skin tear or a venous ulcer, we recommend typically a non-adherent foam, because the non-adherent foam can just be applied on top of the dressing, on top of the wound, and then you can secure it with wrap gauze, or if it's a venous ulcer, with a compression wrap. If you have a lot of trunk wounds, you usually do not want a non-adhesive foam, because then you've got to turn around and add adhesive. So if you're looking at non-adhesive foam, you should be thinking extremity wounds. For trunk wounds, you have a choice. You can use a foam that has an adhesive border, or you can use a fully adhesive foam. The advantage of using a fully adhesive foam is that it will stick very securely all the way around the wound. You never have to worry about it sticking to the wound itself. So no matter what the shape or size of your wound, the wound itself will be kept moist. There will be no adhesion to the wound surface, but you'll get very good adhesion all the way around the wound, which will minimize the risk for drainage to track onto the surrounding skin and cause maceration. So in general, our recommendation is most of your extremity wounds are best handled with non-adherent foams. Most of your trunk wounds are best handled with adhesive foams. Finally, you should know that there are different types of adhesive. Most companies are now coming out either with a silicone-based adhesive or a gel-based adhesive that is designed to be much more skin-friendly for our patients who are very fragile, like our neonates, our geriatric patients, and our critically ill patients. Sounds like everybody, doesn't it? What's the difference? Well, I can put this dressing with silicone adhesive right on top of hair. And when I take it off, it causes no discomfort because the silicone is not tearing the skin. So the advantage is that you can use a foam that puts adhesive exactly where you need it, that's not going to come loose, but you will not cause trauma or pain with removal. If you're working in a geriatric facility, if you're working in a pediatric facility, if you have a lot of very vulnerable patients, you want to make sure that your adhesive foam is either silicone-based or gel-based, that it's gentle adhesive and is not going to cause problems with removal. Okay, so foams are very widely used for management of shallow dry wounds. Your other choices, not surprisingly, flat alginates. So let's say I have a very wet venous ulcer. I could put down an alginate and then apply my compression wrap. If it's super, super wet, I could do alginate plus foam and then my compression wrap. Or I could do my hydrofiber, which is here somewhere, but I don't know where. Here it is. I could do my hydrofiber plus wrap gauze or hydrofiber plus foam. So for extremity wounds, you have a number of options. You can use your flat alginate, you can use your flat hydrofiber, you can use foam, you can use alginate or hydrofiber in combination with foam. Any of those are very appropriate. Now if you'll come over to page 143, I wanted to talk briefly about contact layer dressings. Contact layer dressings are appropriate for any superficial wound, especially on the extremity. So contact layer dressings are always appropriate for skin tears and for any other wound where you can use wrap gauze to secure. Probably the most widely used contact layer dressings are Adaptic. Most of you have used Adaptic. So it's non-woven gauze impregnated with a modified petrolatum product. Okay? Some of you have used Zeraform gauze. Again, non-woven gauze. I want you to start paying attention to woven versus non-woven. Non-woven gauze impregnated with a weak combination of bismuth salts, which makes patients think that it's medicated. It smells medicated. It looks medicated. I've never seen any data that shows that it has a compelling antibacterial effect, but I've also never seen any data indicating any toxicity. So, Adaptic, Vaseline gauze, Zeraform gauze, all contact layers. What do? They keep the wound surface moist. They keep the wound surface protected because they're not going to stick, at least not for the first 24 hours. They allow drainage to pass through for absorption by a secondary dressing. So a lot of agencies have a skincare protocol that involves application of Adaptic or Vaseline gauze or Xeroform gauze, covered with like a Surgi pad, and then secured with wrap gauze. Very appropriate, because the contact layer will keep the wound surface moist and protected. The Surgi pad will absorb any excess exudate, and the wrap gauze holds everything securely in place. There's another type of contact layer that is available. It is your silicone-based contact layer. So a lot of you have worked with Mepitel or Mepitel 1. And you know that because it's silicone, it's very adherent, but it's also very skin friendly. You can actually leave this in place for 7 days. Any exudate will pass through for absorption by a secondary dressing, then you secure it with wrap gauze. So again, very easy to use, great for the patient, great for the wound. Here's the thing, staff have to understand that this is left in place for 7 days. This is not Adaptic. If they take it off every day and throw it away, it becomes cost prohibitive. If they leave it in place for 7 days, it's going to do exactly what you want it to do. So contact layer dressings, always an option. And then the last category of wounds we want to discuss are your shallow dry wounds. These are typically wounds that are almost healed. They're in the process of epithelializing, or they're very shallow wounds that are newly occurring. So maybe a skin tear that's not severe, or an abraded area over the trunk, or an epithelializing pressure ulcer, or a newly healed wound would fall into this category. Now, what's out there? One option is to use a solid gel dressing, and I'm going to show this to you now, and we'll show it to you when you're on site. But let me just say to you, if you don't have this, it's okay. This isn't something that everybody has to have. What you want to have is one good option in each category. The nice thing about this silicone-based gel dressing is that it's very conformable, but it's non-adhesive, so it won't cause any trauma with removal. If you have an extremity wound, it's easily secured with stockinette or with wrap gauze. If you are using it for protection, like I've used it sometimes to protect bony prominences in spina bifida kids who have major kyphosis and they have very prominent vertebral columns. I've used it to protect newly healed extremity wounds and burns in kids because I wanted to protect the area from trauma, from friction, but I didn't want any damage to occur with removal. Because this one's glycerin-based, it does not dry out and it will not macerate the surrounding skin. There are also some water-based solid gels. In my experience, they're used less than the glycerin-based because the water-based is much more prone to macerate the surrounding skin and to dry out. Okay, now if you come to page 144, hydrocolloid dressings. Now these have been very widely used in the past, and a lot of people have had very negative experience with hydrocolloid dressings, typically because they were being used inappropriately. So we have to understand how these dressings work, and if we understand how they work, and if we use them appropriately, we'll get good results. So hydrocolloid dressings are adhesive wafers, and the wafer is made up of little hydroactive particles, meaning the little particles will interact with fluid and swell with fluid. What makes hydrocolloids nice is that it's peel and stick. It's like a Band-Aid. So very easy to use, very easy to teach someone to use. The negatives are that if the wound is very wet, this hydrocolloid is going to be overwhelmed very quickly. Then it melts down and can make the whole area much worse. In addition, people frequently try to use this in the sacrococcygeal area, and it's very difficult to get a good seal there. They absolutely have to fold the dressing in half and start at the center and then fold out, or they stand not a chance of getting a good seal. They can't go from side to side, so you have to really teach people how to apply them. We've already talked about the fact that hydrocolloids are totally occlusive, so they should not be used for infected wounds. We also mentioned the fact that they're contraindicated for use with dry eschar because instead of creating a fluid environment that supports autolysis, they'll just absorb all moisture into the dressing. So they're contraindicated for very, very dry eschar. They're contraindicated for wounds with any significant exudate. They're contraindicated for infected wounds. And they're not the best choice for sacrococcygeal because it's so hard to get a seal. But there are definitely areas, trunk wounds, extremity wounds that are almost healed that just need protection, for which hydrocolloids work very well. Now, as you know, a lot of our superficial wounds that have limited exudate are located in the perineal, perianal area, frequently due to friction and exposure to urine and stool, or to a combination of friction and diaphoresis. And you think, okay, so I've got this wound that's immediately adjacent to the intergluteal fold. How is that going to work? If it's right in the crease, right in the natal cleft, how is that going to work? Am I going to be able to get a dressing to stick there? And the answer is no. So what you want to do is you want to use one of your thick moisture barrier paste, one of your zinc oxide type products. You want to put a thick layer of zinc oxide over the area. And then you have to teach your staff how to remove it appropriately without causing further trauma. So they have to know you want a thick layer. You don't want to take it all the way down to the skin every time. If you have to clean the patient up, you want to take a wet cotton ball or disposable washcloth, wet it with warm water, with mineral oil, with a perineal cleanser, and very gently remove the soil portion and then reinforce. If you happen to use Una's boots and have visco paste or a similar product, the zinc oxide gelatin impregnated gauze, you can do fan folded strips of the visco paste over the denuded areas on the buttocks, and that creates a protective dressing that doesn't tend to transfer to the underpad or to the brie. We'll show you some other things when you come on site about a clear protective plastic film that you can use to create a cover dressing. So you almost always end up using a zinc oxide based product for your perineal wounds, and then you have to think, what am I going to use to create a cover dressing so that it doesn't all transfer to the underpad, so that I don't get such severe soiling and secondary trauma from paste removal. Now, if you come over to page 145, transparent adhesive dressings, of course, you know very well, your Tegaderms, your oxides, your biocclusives, whatever. And you know that this has zero absorptive capacity, so it's going to be used only for protection. But if you have a newly healed wound and you just want protection, and you can get a good seal with this, you can put it down and just leave it on, and it will totally protect that newly healed or almost healed area from friction, because it acts like another layer of skin, and you can literally let it work its way off. Okay? And contact layers we have already talked about. So could I use my Adaptic, my Xeroform, my Mepitel for a relatively dry one? Could I put this on a skin tear that had very little drainage, this on a skin tear with very little drainage, and secure with wrap gauze? Yes. With these, I'm going to have to monitor very carefully because I don't want to let it dry out. So I might have to change more frequently than I would change with a wet wound. With this one, it's silicone. It's not going to dry out, not an issue. I can put it down, I can put gauze on top, secure with wrap gauze, leave it for 7 days, come back, and probably it will be healed when I come back. Okay, so we've kind of walked through the major dressings that are out there. When you come on site, we will be going through these again, and we'll be, actually passing them around and wetting them down so you can see how they differ in their interaction with fluid. But right now, when you're studying this section, basically I want you to focus primarily on the grid so that you know which dressings go into wounds or filler products and which ones are just cover dressings. And I want you to know which ones absorb and which ones hydrate. The only dressing about which we ask very specific questions are hydrocolloids in relation to infected wounds. Okay? Thank you very much. And in our next session, we'll be talking about management of refractory wounds.